Why don't we go ahead and get started? My name is Nicholas Franco. Thank you all for coming to the ACP Long COVID Interest Group. Just a reminder, all of our recordings are on YouTube. I send the link out periodically, and to look out for that in the email, or you can search ACP Long COVID on YouTube to get to all of the recordings. Um, with that, I will kick it over to Dr. Chopra to introduce our guest for today.
Thank you, Nick. And today's session was long time coming. I'm actually behind in bringing Dr. Jason Goldman to this platform, and we are so happy to have him here today. Dr. Goldman is an infectious disease physician at Swedish, and he is our very own Recover principal investigator here in the Seattle site. And he is going to talk to us about the research projects, trials that he has underway for long COVID. He has been working with Recover for a long period of time. And his research is actually very, very relevant to us, especially primary care physicians who struggle with finding these resources for our patients. Welcome, Dr. Goldman. It's so wonderful to have you here today, and I'm happy that you can share this information with everyone today.
Great. Thank you so much, Dr. Chopra, for that very kind introduction, and thanks for inviting me to speak here with the Washington chapter of the ACP and the Long COVID Interest Group. Let me share my slides here, and okay, so thanks again. I'm Jason Goldman from Swedish Medical Center in Seattle. I'm also affiliate faculty at University of Washington in the Division of Allergy and Infectious Disease and at Fred Hutch as well. And we're going to talk today about clinical trials in long COVID. There are my disclosures. I also want to give some acknowledgement to Wes Ely from Vanderbilt and Chris Vanderwalker from the VA, who've kindly shared some slides with me for this talk. So what we'll talk about today is a brief introduction. I think this group probably needs no introduction about long COVID, but I'll just go through a couple key highlights that'll sort of ground us in the clinical trials to come. I talk very briefly about pathophysiology. I think there's a lot there, and we could spend a whole hour on that alone easily, but we'll just, I think, focus on a couple things that might make some of the clinical trials we're doing more relevant. And then I wanted to focus on the clinical trial REVERSE-LC, which is a NIH-funded study of baricitinib. It's a randomized controlled trial. And then we'll talk about how to get involved. All right, so just starting off, let's talk about a brief case example. I think many of you on the call will be familiar with this type of a presentation. It's a fictitious case, but I see many people in my clinic that have a very similar profile. This is a 38-year-old man who was previously healthy. He told me that he used to jog a few times a week, up to about 10 or 12 miles weekly. He's employed, he has 2 children, and then he got sick with COVID in June of 2022. He had a flu-like illness. He wasn't hospitalized, so in the medical community, we might call that mild COVID, but it didn't feel that way to him, and he never really recovered. He said to me, "I'm a shell of my former self." And a lot of patients have said such a similar quote to me or a variant of that. Some of the symptoms include debilitating fatigue and brain fog. Some of the manifestations of this, quote unquote, brain fog are trouble focusing at work, forgetting names and words, having trouble with organizing life tasks that previously seemed easy to him. And then, he uses a bunch of different tactics to try to accommodate, including pacing, so sort of slowing down when he has to physically or mentally exert himself. And this is a picture just from the REVERSE-LC website, and we'll talk more about this trial in a few minutes. So here are some of the common manifestations of long COVID. We covered some of the most common in the case example there: fatigue, brain fog, autonomic dysfunction, and a whole host of other symptoms can go along. There can be up to 200 or more symptoms. Psychiatric symptoms are actually fairly common. This picture on the right of the slide is actually from the New York Times. It was my patient that I treated when he had acute COVID. He was a young man in his 20s, And this was the vision that came to him when he was on a ventilator with COVID. So he was really kind of traumatized by this whole event and had, pretty suffered from pretty bad long COVID. And it had this post-traumatic stress type of flavor to it. This is a study that I love. I think it really captures the multi-system nature of long COVID. It's from the Al Ali group at the VA, pretty early in the pandemic, but it just shows that long COVID diagnoses and symptoms, go across all different organ systems, and they seem to be more common the more severe the initial COVID is. This type of an approach has been validated outside of the VA system as well. There's not a lot on recent epidemiology of long COVID. These are the most recent studies I could find. And they're a little dated now, like data from 2023. A little bit on the left side, that was a recover study that got some EHR data into 2024, but nothing that I could find, sort of speaking to prevalence or incidence more recently than that. But at that time, at least, the prevalence and incidence was relatively high. So, about 20% perhaps of people getting COVID might develop some sort of long COVID symptoms, and prevalence up to 6% or so of the whole US population. So really a big, morbidity that we're dealing with this sometimes debilitating condition. I'm sure everyone here knows about the National Academy's definition, but I think it's just is worth mentioning. In 2024, there was a big process at the National Academies to put a formal definition on long COVID. This is a pretty catch-all definition, and it can be any sort of symptoms or conditions that manifest after a SARS-CoV-2 infection and persist for at least 3 months. There's a lot of examples here. But this framework definition here specifically talks about needing to, potentially define it more narrowly for certain research studies. And that's a key aspect. This is a framework. It's an umbrella definition that can work for clinical care, can work for, disability claims, it can work for research, but, often it might need to be narrowed to some degree, especially for research studies. All right, so again, briefly on the pathophysiology, we won't talk extensively about this, but there's been multiple different proposed mechanisms of long COVID or a post-acute sequela after COVID. Some of these include immune dysregulation with or without reactivation of underlying latent viruses or persistence of the SARS-CoV-2 infection in tissues. Microbiota dysbiosis, autoimmunity and immune priming, blood clot and endothelial abnormalities, and dysfunctional neurologic signaling, for instance, the vagus nerve or the serotonin system. So, very heterogeneous in terms of the symptoms, very heterogeneous in terms of the underlying mechanisms or pathophysiology. And they might fall into these various buckets, as we saw in the last slide. And one or more of them might be happening at the same time. And some of them might be interconnected, some of them might be completely disparate. This was a paper that we did from an observational cohort study at Swedish with our partners at Institute for Systems Biology. This is Jim Heath, who led the multiomics component of this study that sort of defines some of these mechanisms. This paper is from 2022. And, there's been a lot more research into this field, kind of confirming a lot of different, very persuasive direct evidence of many of these different hypotheses. So this figure was from a review by Mike Peluso and Stephen Deeks in Cell a couple of years ago that kind of talks about some of these different mechanistic hypotheses and where we might intervene with therapeutics to kind of break up some of the problems going on. And this figure kind of focuses on immunologic targets and acute inflammation. So we'll talk more about this, and I'll show you this figure again too. All right, so diving right into clinical trials, I'll do a quick overview of RECOVER first, and then get into more detail about REVERSE-LC, which is, I think, a very exciting trial that's ongoing right now. And we'll also talk about how members of the Washington chapter of the ACP can get involved. All right, so a few years ago, there was a lot of negative press about long COVID and therapeutics. This was from Stat News in 2023, sort of showing kind of an empty pill bottle, so no treatments available, and kind of people suffering, wondering when it was going to come. This was a review of all the studies I did on clinicaltrials.gov about a year ago now for a grant application. And, I went through and searched clinicaltrials.gov for long COVID and put on filters for interventional and phases 1 to 4 and, found, 133 results. So there's, the pipeline is filled now with lots of different studies looking at all of these different mechanisms that might be underlying. And I categorize these into, major different categories: antivirals, immunomodulators, neuro or psychoactive therapies, and cardiometabolic agents. And we're going to talk about 3 of these today: nirmatrelvir or Paxlovid, baricitinib, and bezisterim. RECOVER. So the NIH started an enormous national effort called RECOVER, which has multiple components to it, including an observational component, an autopsy component, a clinical trials component, an EHR component. So, a really very big investment in trying to understand the underlying pathophysiology of long COVID and develop treatments for it. So we're, participating as a site at Swedish. Our hub, the Pacific Northwest hub, is led by Institute for Systems Biology, and with Jim Heath and Helen Chu and I are multiple PIs on that as well. We have some other institutions, including Cedars-Sinai in LA and Providence Spokane. So we've been, studying a fairly large cohort, for a couple of years now, and we're going to a second phase of this. A lot of mechanistic work is coming out of this, a lot of epidemiologic studies. And a kind of a sister part of this observational trial is the clinical trials platform. So we're also in the second round of clinical trials now. The first round are, shown here on the right part of the slide. There's different trials studying autonomic dysfunction, cognitive dysfunction, exercise intolerance and fatigue, sleep disturbance, and viral persistence as some of the components or phenotypes or mechanisms that might be underlying long COVID symptoms. At Swedish, we participated in one study that was RECOVER Vital. It was a study of Paxlovid versus placebo. And the Paxlovid could be given for 15 days or 25 days, and placebo could be given for 25 days or this second part of that 15-day arm. And there are 3 symptom phenotype groups in this study: exercise intolerance, cognitive dysfunction, and autonomic dysfunction. And this study has completed. It's finalized and analyzed, and it's under review at a major journal now. But there were some other already published Paxlovid studies at this point that showed that this was not an effective therapy when used at the doses for the durations prescribed and used alone. And we're still waiting on the final public results of RECOVER Vital to be released. So the second round of RECOVER long COVID trials is called RECOVER Treating Long COVID, or RECOVER TLC. It's being run by the Foundation for the NIH, which is kind of organizing. And there's been a big process, a lot more transparency this time in terms of which agents were selected and how they were selected. They did a big call for proposals. They got over 500 submissions, categorized them, and reviewed all of the potential proposals. The current trials that are moving forward are these four. There's low-dose naltrexone, baricitinib, which we'll talk about in depth, a stellate ganglion block, and a GLP-1 receptor agonist study. So this is where these four trials are in the pipeline here. They've gotten catchy names now. So we have Tame LC, Brave LC, Reverse LC, and Block LC. Tame LC is the GLP-1 receptor agonist. This just finished public comment, and the full protocol is now being developed. The only one that's currently ongoing from this sort of second tranche of studies from Recover TLC of NIH is this Reverse LC study of baricitinib, which is a JAK-STAT inhibitor. All right, so let's talk about Reverse LC. It's the randomized double-blind placebo-controlled trial evaluating baricitinib on persistent neurologic and cardiopulmonary symptoms of long COVID. So this is a very interesting molecule that I've actually caught my eye way back in February of 2020. This article in The Lancet came out. That was really before we knew that SARS-CoV-2 was circulating in the US, and we were just kind of reading about it, the reports in China, and people were dying of this mysterious new illness. There was this, cytokine storm that had been kind of elucidated at this point, and these authors from the UK did a artificial intelligence knowledge graph, and they screened the whole pharmacopoeia to look for agents that might work against long COVID, and baricitinib came up as a big hit. So it inhibits the JAK1 and 2, which is a sort of a central feature in the inflammatory cascade, but it also had these other interesting effects on this AAK1 and GAK, which had to do with the viral endocytosis and viral entry into cells. So this agent was actually selected by the NIH in the ACT-2 trials, and then also the Eli Lilly, the maker of baricitinib, pushed forward a program in parallel with the NIH's studies. This is what I got involved with. I was a co-author on this series of papers that came out from the Cove Barrier study, along with Vince Marconi and Wes Ely, who kind of led the study from the academic side. We studied baricitinib in acute COVID, including in a cohort of critically ill patients who were on mechanical ventilation or ECMO. And what these studies showed is that they didn't block progression, but they did result in decreased mortality. So these were big findings in these studies, and these led to the FDA approval of baricitinib for the treatment of acute COVID. There's obviously some careful selection that you need to do of patients, make sure they don't have bacterial pneumonia or other active or latent infections, recent blood clots or malignancies. But this was from these pair of studies with ACT-2 and the Cove Barrier, it showed great success in treating acute COVID. So now enter in the pathophysiology of long COVID, and Wes Ely and Vince Marconi applied for NIH funding to study baricitinib in long COVID. So the other trials where baricitinib was shown to be effective were acute COVID. It was now going to be tried in long COVID. And this is a kind of a figure. It's a little bit busy, but it has a lot of these mechanisms and how they might flow, what might be upstream or downstream. And what you can see here is that immunomodulators appear in multiple different places. There might be Obviously, in acute COVID, the cytokine release, immunomodulators might work there, but is there self-sustaining inflammatory signaling? And that's been shown in a lot of translational studies now. And how might that affect downstream events like the prothrombotic state, or microvascular ischemia or neurologic demyelination? So this is where baricitinib might have potentially multiple effects at different levels of the presumed long COVID pathophysiology. In red are all the areas that might be affected by the JAK-STAT pathway that baricitinib inhibits. So here's that figure again from the long COVID pathophysiology, and JAK-STAT inhibitors or IL-6 inhibitors are sort of postulated to be key central agents to block in the pathophysiology and from acute inflammation to post-acute inflammation. So here's from the website of Reverse LC. You can go to this website and see more about the trial. It's geared towards patients predominantly. This clinical trials is geared towards clinicians. I'll send these slides out and you'll have the links to both of these. The primary objectives of the study are to determine safety and efficacy of baricitinib versus placebo on objective neuropsychological outcomes at 6 months follow-up in participants with neurocognitive syndrome of long COVID. Secondary objectives include determining if there's cardiopulmonary effects to baricitinib, specifically POTS and dysautonomia, exercise capacity with peak VO2 testing that's measured by cardiopulmonary exercise testing and tilt table testing, a functional status, quality of life, and other time points after a follow-up. And there's also many exploratory objectives that have to do with biomarker development that we can talk a little bit about as well. So how it works, the total study is planned to enroll approximately 550 adults who previously had COVID and are experiencing problems with memory or thinking. As I mentioned, baricitinib is a JAK1 and JAK2 inhibitor. Patients will be randomized 50-50 to baricitinib or placebo, and then they'll take part in a schedule of events that goes over a 12-month time period. We kind of consider this to be, quote unquote, high touch study because there are quite a few visits and biosamples and cardiopulmonary exercise testing. So a lot of, patient-reported outcomes data is going to be generated. A lot of biomarkers will be analyzed, and there'll be, quite a lot of information gleaned from this test, from this study, comparing the baricitinib to the placebo groups. This study was also designed in collaboration with the patient-led research collaborative. So patients who have lived experience and advocates for patients living with long COVID, helped in all aspects of the study design, and they had, really nice kind of grading as kind of an ideal or a great study. These are some of the kind of voices in the patient advocacy community. On top here is Hannah Davis, who's actually been quite influential in terms of publishing thought pieces on long COVID. Here's what the study looks like in terms of the nuts and bolts. Patients provide informed consent and have 30 days to be screened and randomized. And then there's approximately monthly study visits up to 6 months while the patient's on study drug. And then remote visits after that for the next 6 months until one final in-person follow-up visit. Safety labs are drawn on all of the visits during the active treatment component of the study for 6 months. But safety labs at some of those draws and safety labs and biomarker draws at others. Here's the whole team at the recent investigator meeting. There's been an expansion from 4 pilot sites to 15 sites total. So, our site at Swedish is one of the expansion sites, and we've now gotten going and have enrolled some participants. I'll talk very briefly about DRESS-LC, which is another study that we just wrapped up enrollment on. This is a study of bezisterim, which is a neuroactive anti-inflammatory agent. This study is has enrolled actually 208 persons who are living with long COVID and have fatigue and neurocognitive impairment. Bezisterim is an investigational drug. It's not FDA approved for any indication. Baricitinib is approved for other indications, but bezisterim is not. It works by reducing inflammation via the ERK and NF-kappa beta stimulated cytokines, including TNF alpha, and in the central nervous system. So the predominant mechanism is working on CNS inflammation. And this is a lower touch study where not a lot of additional biomarkers and physiologic examinations, more kind of questionnaire-based outcomes. So might be a little bit easier for some people to participate in without the rigorous follow-up schedule. All right, so just kind of a couple thoughts as we close, and then I'm happy to save a lot of time for questions here. But I know this group, and especially Dr. Chopra, herself, are working on framing how to take care of patients with long COVID, and this is kind of one framework that I like. This slide was shared to me by Chris Vanderwalker at the VA. But we think about different things. There might be post-critical illness aspects. There might be really unexplained aspects that kind of fit with other syndromes. And there might be direct tissue damage that had resulted from the initial illness. So we can think about how to address the different components of long COVID differentially based on what we speculate is the underlying cause. So if someone has orthostatic symptoms and they meet a POTS definition, you can do some simple bedside testing like the Nasaline test. We might give certain treatment approaches, syndromatic treatment approaches like hydration and salt loading, compression, and other things like that. And there's a lot of overlapping syndromes that someone with long COVID might fit in that we can kind of knock off and improve on some of the symptoms. And as clinicians, that's maybe our role to differentiate some of these and try to provide therapies where we can. But a lot of what we might be left with is unexplained, and that's where I think that the randomized controlled trials can really add a lot. We don't want to be giving potentially harmful therapies to someone that we don't have a good sense if they're going to benefit from them, and they might experience kind of a well-known side effect profile. So I like this kind of framework here, acknowledging your patients, their experience is real. Think about syndromic management, excuse me. So what symptoms are they experiencing? Can those symptoms be ameliorated with some sort of a strategy that we might borrow from another condition, or might be common approaches to common symptoms, and then managing expectations. Negative tests are not disbelief. Listening and validating is an intervention in itself. We haven't talked about the sort of placebo arms of some of these trials yet, but I'm happy to answer questions about that. That's kind of an interesting emerging area. But probably the validation of participating in a trial or of a astute clinician who can perform that function might have probably pretty good therapeutic benefits in and of itself. And then referral to randomized clinical trials, I think, is an important part of the current framework of caring for patients with long COVID. So getting involved. How can members of the Washington chapter of the ACP get involved? I've kind of broken this down into two boxes here for providers and for patients. For providers, I've given some links here of how to get involved with the efforts at the NIH and the Recover Treating Long COVID. You can follow these links and sign up for newsletters, express interest if your site wants to host a trial. They are still looking for sites for many of these trials. And you can also get in touch with me if you have any questions about these and how to get involved. And then also I'd encourage you to refer your patients. If they are in a distance that they can come, to Seattle to participate in trials, we'd love your referrals. Here's my email address and respiratory disease research at swedish.org, RD research, and our study phone. So, if you want my cell phone, that's fine. Just email me and we can get in touch. We'd love to have your referrals of your patients to long COVID trials. Patients can self-refer as well. You can self-refer on the Reverse LC website, which is listed here. We also have a registry. It's a long COVID registry where patients can sign up and hear about all the different trials that might be coming through the pike at Swedish, and we do have probably a couple others that will be in the future. Right now, we just have the Reverse LC trial open, and patients can use this QR code and fill out a brief questionnaire, and then they'll hear about any trials that come up that we'll be participating in. All right, so thank you for your interest and time, especially while the U.S. men's team is playing the World Cup game now. I appreciate your attention, and also to the participants of our studies that have donated their time and their energy and their biosamples. We appreciate all of them as well. So I'm happy to answer any questions.
Thank you so much, Jason. This has been so incredible. It's so wonderful to see the other side of, a sort of science where research is actively going on, trials are going on, and how researchers are thinking, what all they are taking into account, how are they choosing the drugs to test for this condition, which has no active treatment available at this time. So thank you for sharing these. I also want to share my own experience referring patients. And I think, first of all, we are so fortunate to have a recover site right here in Seattle. We can refer our patients. There is an ongoing active trial for a medication which seems to be promising. And I think this in itself is huge for people living in the Northwest in this area, because for patients, it is very convenient. They don't have to travel all the way to other parts of the country. Jason, you talked about the Reverse LC. I think that is your active recruiting trial that's available at this time. I have my own patients I have referred to you, and you have been very, very responsive. In fact, you've been able to get people in, you've answered their questions. That has been very smooth process for them. And I really want to highlight that, because sometimes physicians, they run into a roadblock when they are, first of all, finding trials is hard, and then referring patients is harder. So I wanted to find out from you, who is the ideal candidate for the Reverse LC trial?
Yeah. Thanks for that question. I actually have some extra slides here so we can look at the inclusion criteria. But basically, can you see my screen now? Can you see my screen again? Okay, great.
Yes.
So your patient with long COVID who has neurologic symptoms is really the ideal candidate for reverse LC. So trying to make it as simple as possible. If they have a well-diagnosed long COVID illness and they have a neurologic dysfunction or brain fog, phenotype, that's who we're looking for. The expansion sites for reverse LC are only enrolling patients with documented SARS-CoV-2 infection that preceded their long COVID symptoms. So if patients tested, with a home test and didn't document it, unfortunately, they don't qualify for this study. So that's been one area where we've had trouble getting some people who we thought were, quite good candidates into the study if it's not documented. Documentation from the clinician in a note concurrently with their, acute illness, that counts. So if they have a positive PCR test or a picture of their antigen test, or if it was documented in their clinical chart notes, that counts. And then here are the clinical evidence of long COVID. One or more symptom that's new or worse than SARS-CoV-2 infection. The symptoms can have been from the beginning of the pandemic up until at least 6 months prior to screening. So the NASM definition or the National Academy's definition is 3 months, but this is really kind of wanting to enroll patients with a kind of a persistence at 6 months or more. It has to have effects on quality of life, everyday functioning, and it has to be at least partly bothersome to the patients. And they have to have cognitive impairment. So I like to think of the ideal candidate to refer as someone who has, in your mind as a clinician, well-defined long COVID with a neurologic dysfunction phenotype. And then, we do the symptom screening with this ECOG. That's not something that you need to do as a referring clinician. It's just in your assessment if they have neurocognitive syndrome. That's who we're looking for. Here's what the exclusion criteria looks like. Some of the things that you might anticipate if they've had recent major cardiac events, DVTs or PEs, malignancy, if they have untreated latent infections or active infections. These are some of the things that'll disqualify them. And also if they've had another infection-associated chronic condition or IACC that preceded long COVID, they don't qualify. So if they had, for instance, ME/CFS prior to long COVID, they won't qualify for this study.
So, Jason, if as a primary care physician, I were to explain this medication, and again, the patient doesn't know whether he will or she will get the medication or not, but how do I explain, how does this medicine, what is the proposed mechanism, how would this work to alleviate their symptoms?
Yeah. So baricitinib is a medicine that works on inflammation, and it's FDA approved for a number of different rheumatologic conditions like rheumatoid arthritis and others. And it breaks up inflammation. So that's how it works, and that's how it's being proposed to work in long COVID. And in the study, we do a very careful screen to make sure people don't have risk factors that they might be more at risk for some of the the known side effect profiles of this medicine. And we do monitoring throughout the study for kidney functioning and lipids and other things that can be side effects of this medicine.
So as far as referral mechanism, providers or physicians should fill out the QR code or the form that you mentioned, and they can also contact you.
Yeah, so let me just clarify that. Thanks, Anita, for mentioning that. The QR code is for patients to fill out for the registry. So providers don't need to fill out the registry link unless they are suffering from long COVID symptoms themselves. But this is really the QR code's geared towards patients. providers can just contact me or my team directly. And I'm happy to give you my cell phone and just send me an email and we can communicate and we'll have immediate text access with each other. You can just send over your patient's information to me after you get their consent to send it, or assent. Doesn't need to be consent. Just they're if they're okay with being referred for the study, you can pass their information to us.
And I also just want to share that, as we all know, these patients are actually very committed, and they are very well sort of not only aware of long COVID research going on around them, but they are also very committed to their own recovery, and they are very, very compliant. So I think there's a lot of partnership between physicians and patients for this condition. So I know that for my patients, when I have shared this QR code with them, they have really, I actually sent through my chart messages to them who I felt would be good candidates. So just to share it with the physicians here, please feel free to share this information with patients.
Yeah. And Nick's going to send out this flyer in a PDF format so that you have it. You can pass this out to your patients. It's approved by the Vanderbilt IRB for distribution in the community. So it's completely fine to share this. Patients can use the QR code and sign up directly for the registry. There is, kind of a queue that we've been working through. As you can imagine, there's been a lot of interest in the study. Again, I think we do try to prioritize people who kind of self-refer as we think it sort of shows their motivation, and also we try to prioritize direct referrals from clinicians in the community. If your patient signs up on the registry, also feel free to reach out to me and share the information if your patient wants that. And we can try to get to them sort of sooner in the queue. So that's sort of how we've been operating. And again, Nick will send out this flyer after the meeting.
And then, Jason, do you communicate with the primary care physicians? I mean, does your team communicate with them throughout the study? Is that something that they should expect? And is there like a warm send-off kind of situation once the trial is over?
Yeah, we will be communicating, especially if there's any lab abnormalities. So, some of the lab abnormalities we have protocol directed kind of adjustments to the medicine. For instance, we might adjust the medicine throughout the study if the kidney function changes or if the lipids change. But we'll also be communicating to the primary care physician if there's other untoward labs that don't have protocol directed adjustments to do. If you want to get regular communications from our team about the study visits, again, just communicate with me. We don't send every study related note to PCPs because we don't want to overwhelm people. But if that's helpful for you, we're happy to copy you on communications.
And then, Jason, as far as you are part of the Recover, you talked about the stellate ganglion block, you talked about the low dose naltrexone. I think those are also very exciting trials that are going on. Are there, sites nearby who are enrolling for those trials? And can you briefly please touch upon those two trials also?
Sure. Let me go back to those actually. We can talk about them briefly. Okay, here we go. Let me actually do this, I think, because this sort of shows where they are in the phase. This farthest green box here for reverse LC, this is the baricitinib trial that we discussed already. This is in recruitment phase. None of these other trials are yet recruiting anywhere in the country. So they're still really in the design phase. TAME-LC, which is the GLP-1 receptor agonist trial, that one just finished public comment, and there'll be, the full protocol is under development with the public comments, and then FDA and IRB approval processes, and then and site selections, and then it'll open to recruitment after that. This TAME-LC study is looking to recruit up to 75 sites around the U.S., so it's going to be quite a big study. 750 patients. And the low-dose naltrexone study is actually being done mostly in sort of, adolescents and young adults. I'm not totally sure, all the rationale that went into that decision making, but this study is also in, a kind of a little bit farther along in development, but still not recruiting yet. And the stellate ganglion nerve block study, I think this one is likely to be a little bit of a smaller study in terms of how many sites might be signing on. I think, the sites will probably need some specialized treatment expertise to deliver that nerve block. So many sites might not have that clinical expertise. But yeah, so those links I gave you, you can sort of stay on to get newsletters and hear about when these trials are starting. But all three of the other trials from treating long COVID are not yet open except for reverse LC.
Thank you. This is very helpful.
Yeah, and here's just a little bit of a more about each of these. I think the low-dose naltrexone is obviously a very promising therapy. It's being widely prescribed to patients with long COVID. So that's always a little bit of a tricky situation for a study because many of the people that might want to participate, or might otherwise want to participate, might not because they might have access to it through their community physician. So we'll sort of see how this trial does. I think that, a lot of my patients can't really access this. It tends to be expensive and available in compounding pharmacies. So some people do have trouble getting this. So the study might be able to, capture some people who want to try it but can't get it. And then insurance as well. Insurance doesn't really cover it. And we'll see how this trial does in terms of whether it is broadly generalizable enough to be able to address the insurance barriers to some patients are seeing to getting low-dose naltrexone. GLP-1 receptor agonists, I think for anyone who's in primary care or following, these are kind of being billed as these wonder drugs. They have lots of, pleiotropic effects in different organ systems and by unexpected mechanisms. So I think it's a, potentially interesting agent to try in this condition with long COVID, as there are some cardiometabolic aspects to long COVID. We didn't talk about that a lot today, but we could go into some of the disease associations with diabetes and obesity and other things that the GLP-1 receptor agonists might be very promising to address some of the the comorbidities that might predispose to or exacerbate long COVID type symptoms. And also their purported immunologic effects. So I think all of these are very interesting. I have to admit, I know less about stellate ganglion block. So if anyone has more knowledge about that, I'm all ears because I'm not 100% certain about how it is intended to work. But I guess my really bare bones understanding is that it has to do with parasympathetic and sympathetic tone. But that's about the extent of my understanding on that one. So I don't know, Dr. Chopra, if you know more about how that might work, or if anyone else.
So I actually had patients who got this block done, and And they, I mean, I don't know how they got access to it, but I think it was done by an anesthesiologist for them, and it was primarily to address in them, it was to address autonomic dysfunction.
Mm-hmm.
And they reported temporary benefit, probably for a month or so, and then it reverted back. But again, it could be very individual situation. But then, yes, it is basically to deal with the sympathetic parasympathetic tone, and how that is disturbed in patients who have dysautonomia. So basically, to address dysautonomia is where this is anticipated to have benefit.
Mm-hmm.
But low dose naltrexone, of course, so many of our patients, they are asking for it because they have read it in patient advocacy groups, and some of them do have benefit. And also to GLP-1 drugs, of course, like you mentioned, it is, they are thought to affect many, many different conditions. So if anyone has questions, please feel free to ask Jason at this time. But otherwise, I think that this is a very, very important session, and I'm very happy that you shared not only the information about the trials, but the background, how what went into designing those trials, and especially the stages at which the other recover trials are at. So thank you so much, Jason. Looks like we don't have any other questions, but thank you very much for joining us today. We appreciate your time. We will send out the flyers to people on this call and also to everyone on our mailing list. And hopefully we can, get patients into the trial and benefit from this study.
Great. All right. Thanks, everyone.
Thank
Take
you.
care. Bye-bye.